Hello, good morning, Dr. Davidson.
Yeah.
Hello, good morning, Dr. Davidson.
Good morning, all of you.
Welcome to the Merrill campus. We have a
Welcome to the
full
Merrill
house
campus.
of physicians waiting to look at your case and
We are
meet your
we are
team.
happy to. Yeah, we are happy to be on air. First of all, let me thank the Merrill team, especially Mr. Ajay, for having given us this opportunity. We are from the southernmost part of India, Kerala, the God's own country, Caritas Hospital. Our team, entire team is here. I am Dr. Deepak. With me, Dr. Thomas is here. Now, our head of the department, Dr. Joni Joseph, he's around. Dr. Nice is around. The scrub nurse, we have Jace, we have Maria, we have our technicians, everyone around us. Now, shall I go ahead and introduce the case?
Please do so. Thank you.
Yeah. Are you able to see the live monitor there?
We're seeing you. We don't see the monitor yet.
Yeah. Can you show the live monitor also? Can you show the live monitor there?
And now
Yeah.
we see it.
I hope now you are seeing the okay. Now I shall introduce the case. Run right from the beginning. Well, this patient, he is an elderly gentleman. He was admitted around 3 weeks back with an acute anterior wall myocardial infarction. He was in hypotension. He was in bradycardia too. Could you show the previous run? We would want to see the previous run also. The first one was the right coronary shoot. Please show the right shoot. Okay, this was the. I'm sorry, this is not the first shoot.
We see the right coronary
Okay,
well.
now that's a. Yeah, show that. Jojo, run the first one. Okay, this is the right coronary shoot. He was having bradycardia, hypotension. The procedure was started through the radial approach. You could see that there is a critical stenosis in the right coronary artery. Now we move down to the left system, shows the left system. That's the left main looking okay, the circumflex mild disease, and the LAD was proximally occluded. Next one. Okay, we wired the lesion. Next one, the wire went distally into a diagonal branch. Because he was sick, we didn't bother to shift the wire back into the LAD. We worked with that particular wire position. Next, we did thrombus aspiration. Following that, next one, a stent was deployed. That's a 3.5 millimeter biomime stent. Next one. This was deployed at 16 atmospheres, and following that, there was slow flow. He had a cardiac arrest. Next one, he had VT, VF, all those things happened, and finally we could achieve a reasonable flow in the LAD, and the blood pressure improved, and he was also kept on intra-aortic balloon pump. That was the final result of the left system. And now next one, we again, okay, shows the next image. Okay, we again rechecked the right coronary artery. You could see that it was flowing well. Because he was in hypotension, we had a thought whether we should attempt the non-culprit vessel too. However, we decided that the flow is good, so we wouldn't do anything for the right coronary at that point of time. So next one, and finally he was kept on balloon pump. He improved. Now his LV function is good, and so today we have brought him back for the intervention of the right coronary artery. And show us today's first shoot. Shows the first one.
So overall ejection fraction is preserved?
It's improved. It's almost 50 to 60%. We are so happy that in spite of having so much of slow flow,
Yes.
his LV function had improved so much. It's almost a normal LV function. Now this was today's shoot. We just had a look at the left system.
Beautiful.
The left system is flowing well. Next.
And the diagonal is preserved. I think it's very important.
Yeah, that too is flowing well. And this is just the cine showing that there is some amount of calcium in the right coronary artery.
Yeah.
show
we see that very
show
well.
just the cine alone, just to show that there is a significant amount of calcium there. Okay, now you could see that there is significant amount of calcium there in the
Yeah.
mid portion of the right coronary artery. Next one. So
Yes.
we started the procedure through the femoral approach, a 7 French diagnostic guide catheter. Next. Okay, that's how where we are. This is where we are. You could see that that's a 7 French guide catheter. Because there was some amount of ostial narrowing, we took a guide catheter with a side hole, and that's the first shoot of the day. You could see that there is a critical stenosis, a calcified stenosis, and our plan is to go ahead with IVUS evaluation and then rotablation. Now, can you tell us your thoughts about this particular case for the day?
Dr. Davidson, a heroic case, a very nice case. Thank you for sharing. I think the important aspect for the right coronary here is, number one, the fluoroscopic calcium is impressive in the index lesion in the mid, and your thought of doing rotablation is absolutely probably the accurate one. Is plaque modification is probably a must prior to dilatation and stent implantation. So I think that that's a very good point made. I will ask our expert panel here. Dr. Mamdou, what do you think?
Hello?
Mike, please. Yes. Mics, please.
Okay, now we started doing this procedure with a temporary pacemaker support. Now could we have a small discussion on that? Do you really need a temporary pacemaker support for a right coronary rotablation all the time? Do you all use that, or
Yeah,
you would prefer not using a temporary pacemaker support?
Yeah, I think the point about if doing rotational atherectomy in a dominant vessel like this, the right coronary, should a pacemaker be used? I think you've already demonstrated during the acute phase he was bradycardic. I absolutely would use a TVP. There are many people who can get by with other methods, but I would not do so in a case like this. In a gentleman who's just suffered an anterior wall MI, you do not want to have hypotension. You do not want to have any kind of hemodynamic change, and bradycardia will cause that. So in this case, we would always do a TVP.
Yes, yes.
If there is
Okay, now
a concern
what
in
about
the
IVUS?
cost,
Yeah, please.
so rotablation just and monitoring the heart rate. If the heart rate starts to drop, back off. So this is there is a concern, but I strongly agree. Temporary pacemaker in such scenario is required.
If you don't put a pacemaker, at least have venous access and be ready. Okay? Do not take a chance in a case like this.
What I meant, the complete heart block during rotablation in a super dominant RCA will not happen like that. It heart rate reduced, then blocked.
Whether it happens
Yeah.
slow or fast, you don't
now
want it to
it's
happen. That's the whole point. But I think your point is well taken. So go ahead, doctor.
There's just one in this view.
Okay.
I'm
Now
not too
it's
certain, but
a
in this
routine
view is that
protocol to have a temporary pace.
Yes. Go ahead. Dr. Davidson, go ahead.
Please go ahead.
just
Yeah,
a
now
question
what
on
we
the
have done
distal
is we have
vessel.
wired the lesion. Now
Yeah.
we are planning to do the IVUS evaluation.
You know, my thought, Dr. Davidson, is I don't
Because
know
of
if
the-
IVUS is going to cross that lesion.
What we had in our mind was, if it doesn't cross the lesion, at least we'll know whether it's a subintimal calcium or not. That's number one. Number two, we thought that we'll have a good idea regarding how the proximal vessel size looks like. And number three, we thought we'll just have a idea regarding the ostium of the right coronary arteries, just to see whether it's a significant lesion over there or not.
Okay?
Yeah, as you have mentioned, it's not crossing the lesion. Okay. Now, could you put the IVUS? Could you focus on to the IVUS monitor?
So this is the volcano IVUS. It's a very low profile IVUS.
That's the IVUS. Yeah, that's exactly at the mouth of the lesion where the calcium starts. It looks like almost 180 degree of calcium there, not exactly inside the lesion, at the mouth of the lesion. Now we also feel that the vessel size is almost 3.5 to 4 millimeter. Now shall we do a pullback? We'll do a, we hope to do a manual pullback. Can you do the recording? Yeah, I'll do the pullback. Proximally you tend to see bit of calcium. The vessel size is again almost 4 millimeter, and that's the ostium where you have some amount of calcium there. Can you again make it live? Okay, that's the ostium of the right coronary artery. You could again see that there is some calcium as well as lesion. Now that's it. Now we'll take out this IVUS catheter. This is what we wanted to know. We wanted to know whether there is significant amount of subintimal calcium. We wanted to know the size of the vessel as well as the ostium of the right coronary artery. Now we hope to wire with a rota wire. Prior to that, we thought we'll use a microcatheter to exchange this run-through wire. We'll use a stride catheter.
So that's a very good point in difficult anatomy and calcified disease. I will often take a microcatheter and a workhorse wire and then exchange my workhorse wire for a roto wire. There are two types of rotational atherectomy wires. There's a floppy and a extra supportive wire. The supportive wire will give you some more bias sometimes, but will help you get the burr where you need to get it. We often tend to use only the soft wire, non-supportive wire, and we will usually take one burr as a one burr strategy. Typically it's 1.5 millimeters. Sometimes it'll be 1.75 millimeters. We almost never use a 1.25 millimeter except in CTO or subtotal cases.
Rota wire.
Have we lost our...
Yeah. So in this situation, you would opt for an 1.5 burr, is it?
1.5 burr, yeah. I mean,
that's what we even had in our mind.
Yeah.
So we'll try to cross the lesion with the microcatheter. Now we have the microcatheter near the lesion. We'll cross it and then exchange with a rotafloppy. Thank God. The microcatheter has gone through.
Very nice. Which microcatheter
We have
are you
removed
using?
the run-through wire. That's a stride catheter.
Okay, very nice.
That's Thermos.
Yes.
Asahi, I'm sorry, it's Asahi's. Now we'll go with the rotafloppy.
Now I know you're working, Dr. Davidson, but what is your plan for the distal right coronary lesion? And do you plan to do rotablation down there or only the mid lesion?
No, did you mean the PDA or
The PDA, yeah.
PDA? We thought initially that it's a stable plaque which is around 70%. We wouldn't touch it. But again, we had a feeling in our mind that probably as the case goes through, we might probably change our decision and take a small stent and go ahead there. But definitely we wouldn't want to do a rotablation of the PDA branch.
Okay.
What is your thought on that?
I haven't seen a good view of it. It's a nice dominant right coronary. I think you're probably right. But one thing I've been impressed with is that sometimes you will finish what you think is important to rotablate, and then you'll leave distal disease, and you will not get a good result because you can't expand. So you just have to be sure. Since you have already used IVUS, do your burr, and then you can always evaluate with IVUS.
Yeah, sure. Now, could you focus on to the table? Now we have removed the microcatheter. We have the rotafloppy across the lesion. Now we'll open the burr. Can you get us the 1.5 burr? Meanwhile, can we discuss on the speed of rotational atherectomy that you would prefer to do in this particular situation? Would you all prefer a low speed rotablation, or how
Panel?
is it like?
Well, I have an expert panel, so let's see what they think.
Using 1.5, I go 140. Outside the body, probably 145 because it will drop 5,000 when it's inside the vessel. The higher the speed, as you all know, that it causes platelet aggregation. So we need to make sure that the ACT above the 250.
Anybody different? So we
didn't-
typically go
didn't
one-
hear you properly.
Yeah, I would say that typically I'm doing 160,000 RPMs as my minimum rotations. And I make sure that I don't have
Yes.
decelerations of more than 5,000. But 160 is what I typically want to rotate at speeds in this type of
Yeah,
situation.
usually this is what we do. If it's an 1.25 bar, we usually go for an 170,000 RPM, and if it's 1.5, 1.75, we start with 160,000 RPM, and in case we find that the burr doesn't cross the lesion, probably we tend to increase the burr speed.
Totally appropriate, yep.
Okay, now we do all the 4 important steps. We check all the 4 important steps. First, we have a look at the drip rate. Hope you could see the drip rate over there.
Yes. So you want to
This
make sure
drip
that
rate
the
seems to
roto
be
flush
okay.
is on.
Yeah, it's yeah, the flush is on, it's flowing well.
Yes.
Then we'll check we'll do the speed check. Let's have it at 160, okay? Okay.
So these are all very important points to check outside the body before you're actually ready to do your atherectomy.
Okay, okay. So we have we have set a speed of around 160,000 RPM. The drip rate is good. Now we have kept the advancer knob halfway through so that we could relieve the tension at the before we start the burring. And finally we have the wire clip also intact. We are very religious about this wire clip. At least for the juniors who are seated there, it's extremely important for the wire clip to be in position. So we always check 4 important points. Number 1, we look at the drip rate, we look at the rota speed. Probably we keep it at around 160. Then we make sure that the knob is kept well in position halfway through, and then finally the wire clip. Now once we are set this way, we go inside the catheter. Now we are trying to negotiate it into the catheter, the push-pull technique.
So this is very nice if you're a single operator. It's typically a 2-operator technique. Is somebody is holding
It's
your
like
wire
you don't have to blame anyone for
losing your
have
wire.
to blame anyone for pulling out the wires.
That's right.
I usually stop the brake,
I should also tell you that
then
this
dynaglide
technique.
it.
I should also
Would work.
tell you
You could do that
that.
as well.
Yeah, I should also tell you that this technique was taught to us by Matthew Samuel sir, and we find it really useful.
Yeah, I believe it. This way, you're right. You don't have anybody to blame but yourself. There's one other suggestion of dynagliding into the proximal
that
part
too
of the
is-
guide. That's another option as well.
Okay. Okay, now the blood pressure is okay. Okay, I hope we'll relieve the tension from the knob, and then probably we'll start burring at 160,000 RPM.
Can we see your screen? Angio screen?
Can you show the angio screen?
Very good. We see it. Thank you.
Okay, okay, okay.
Watch the heart rate is going down slowly.
And nothing to worry, he's got some STs that go up. He hasn't gone through the lesion yet, but he has a pacemaker in place. Nothing to worry about. But you see how the patient gets hypotensive. As they lose AV kick, they will get hypotensive. So he's now recovered, and now he can resume.
And now, how long do you routinely wait before you do the second run?
All depends on how the patient is doing. I used to, like I say, I like to let them drink for 30 seconds to a minute, and then begin again.
And flush in between during the
Yes.
rota just to not allow the debris to
To
accumulate.
accumulate, yeah. So just take a picture or just flush everything out.
Normal salah, half and half.
Half an hour.
We usually wait for 1 minute and 30 seconds, hoping that we don't trouble the coronary very often, for the coronary to have a breathing space. Because there was significant brady, we thought we should definitely wait for 1.5 minutes before we go for the next run. Would you agree with that?
I think that's absolutely fine to do. We don't do a minute and a half, but the whole point is to make sure that hemodynamic stability is regained, and then you don't overwhelm the microcirculation with embolic debris that you're ablating. So I think that's a very good point. What I would do here is be a little bit more aggressive to try to get through the lesion, instead of backing out, but just short pecs, but continue to move forward. Because the number
Okay,
of runs
okay.
is also important, not just the length of the runs.
Okay, sure.
This blood pressure is not true. His hand is in the
Yes,
opening.
but you see, as soon as the patient is paced, they become hypotensive. So that was a very nice run, and I like to limit my length of runs to maximum 30 seconds.
Maximum?
30 seconds. You did less, but that was good. As far as the length of run.
We don't usually burn more than 15 seconds.
Yeah. That's these are all 15 to 30 seconds is what's anticipated to be the range of
Okay.
And
Now, if the
had
bird
somebody
doesn't cross
remind
through-
us if it is
Cross
15
through the
seconds,
lesion,
stop.
what are your
and back
options?
off.
I'm sorry?
Well, could we discuss, in case the bird doesn't cross through, following 4 or 5 runs, what all options would you have?
I think for me that there are two options. It's increasing the speed, and if that's not an option, then downsizing the burr.
Okay, okay. Now, if it happens with an 1.25 bar, what would you do? We have had situations wherein after 20 runs, the bird wouldn't cross. So what else could we do at that point of time?
In that case, the thing that comes to my mind is that you're subintimal and you've re-entered, and that's why you're not able to cross.
Okay. Okay.
So you have now completed your job. There you go. Beautiful. Nice. Nice and slow. Beautiful. So you have crossed the lesion. Patient is stable.
Would you just stop with a polishing? Would you just stop with a polishing run, or would you want to have the burr dwelling inside the lesion for a few seconds? Would you ever try to do that?
No, I don't. I think the main thing is to polish and make sure that you've modified plaque, and then you're finished.
Okay. So probably we should just stop with the polishing run. Did you mean that?
Yeah.
Okay.
Why don't we take a picture and see
Now
what it
we'll
looks
just
like?
wait for another 50. Yeah. Now we are very scared to do pictures in between rotor runs because many times we tend to see that there are a lot of air bubbles between the sheath of the rotor catheter and the sheath, so that we tend to create more of air embolism. So I'm just opening the Y connector to remove the air bubbles before I do a
Okay.
cine.
Good point. Yeah, I think you're in good shape. The only area that there's a distal end of that lesion that needs to be polished, but that's neither here nor there. I think you've done a good job of modifying the plaque.
Yeah, we have some ST elevation on the monitor. I think we'll do the last polishing run and come out. So will that be okay?
That's perfect. Good.
So we'll take out the burr.
Yeah, I would do that and give some
Can you have the
vasodilators.
wire?
and-
Yeah. Can you get us some nitroglycerin? Would you prefer giving nitroglycerin or would you give nicorandil?
We tend to give nipride if the blood pressure is okay as a vasodilator of choice. But either one is fine. Yeah, nitroglycerin is okay, but it's not really for what we call, slow flow based on microembolization. Clearly, we found that nipride, adenosine, nicardipine, those are the agents of choice.
What about nicorandil?
You can use nicorandil if that's what you have.
What about?
That would be fine.
Okay. Give us nicorandil 2+2. Before that, I'll just take a small shoot.
Yeah, you just need to dilate this lesion.
Yeah. Okay, I think we'll give some nitroglycerin also because there is some amount of spasm down there.
Yeah, it's going to be fine. I would get the wire out distally, secure the RPL or PDA, whichever one is the biggest. Make sure that you have that distal lesion secured.
Okay. Now we have given 2 milligrams of nicorandil. Next 2+2 we have given 4 milligrams of nicorandil and probably another 50 micrograms of 50 micrograms of SN nitrate.
Yeah,
DTN.
yeah, you see your STs are already improved.
Just to see that the spasm is relieved distally in the vessel. Yeah, we are happy to see that the ST segment is better now. Yeah, now the flow looks better.
Yeah, it looks very good. You're ready for pre-dilatation now.
Run through. Okay, so we'll again go with the run through wire. and we'll probably go with a 3 millimeter balloon, 3 into 15 or 3 into 20 for dilatation. What is your thought on the pressures following post rota? What pressures would you routinely go during dilatation of the vessel?
That's a good question. I typically like to take
Would you go at 12?
I take non-compliant balloons, and I will go to the appropriate pressure to make sure I have eliminated any waste. So 1-to-1 non-compliant balloon at the pressure to prove that I can expand the vessel and put a stent in.
Okay, okay. So we hope to go not at very high pressures, probably at 12 atmospheres or so. We have taken a 318 non-compliant balloon.
Perfect. I think this is looking very good. And I think you're seeing Dr. Davidson spend enough time to be meticulous about vessel prep here, because that's the only way you're going to get a good result in a case like this.
Yeah. We'll go at 12 atmospheres.
Beautiful.
Okay. Negative. Would you always keep the rota wire there as a cutting wire for the dilatation, or would you remove the rota wire?
Neither here nor there. I usually use it as a buddy wire until I'm ready to stent. But I think that it's, you've done such a nice job of prepping this, you could even use this as a primary wire if you needed to.
So now we have dilated the lesion. Now what about the stent length? Would you always prefer stenting right from the ostium of the right coronary artery in this particular situation?
I didn't
We thought of,
yeah, was there a lot
we
of
thought of, yeah. Would you stent right from the ostium of the coronary?
I didn't see the IVUS ostium. Was it diseased?
There was some amount of disease with calcium too.
I'm not sure. Again, based on my view, I would just do the index lesion, but again, you IVUSed it. I would leave it alone and not stent it unless it was obstructive.
Okay. Now, would you want to see could you show us the first view of the other day? There was some, it looked like 50% stenosis of the ostium, and I'll just show you the other image. Jojo, previous run and length. I was actually trying to disengage it.
Yeah, this is why I would just say that I would look at the IVUS run you did and then decide. But I think that the key here is to secure this index lesion.
We have lost the audio signals from there. Thomas, can you hear them?
No, I can't hear you.
We're watching you wire this.
We have lost the audio signals. Jojo shows the previous run so that we can measure the length of the lesion. Okay, now that's a freeze that. This balloon is 18, right?
Freeze.
So what about 44?
Yeah. 44.
Huh?
44.
44.
So their plan is to stent from
3.5, 44.
from the distal to
3.5, 44 biamine.
all the way back.
The signal has got cut.
Does it matter the length of the stent in
How
the
long since we
drug-eluting
started?
stent
Is it
era?
45 minutes now?
Yeah, yes, it is.
I'm sorry?
The length of the stent?
It
With the-
certainly matters in any error. I think
3.5.
that we know that even
Yeah,
with
we'll go with
DES, stent length has a
344.
predictor for restenosis.
Okay, we'll start with.
His IVUS suggested a 3.5 proximal, so it's a large vessel. And so my approach would be a little bit different. The rotobird did not injure the proximal RCA, so it's not mandatory that you have to
Okay.
stent it, in my opinion. But it's a decision you have to make based
So
on the
you would
imaging.
prefer
and
to
your-
avoid stenting the ostium.
Yeah, that's
Okay,
the.
so you would prefer to. Yes, definitely we'll take. Would you want us to have a look at the ostium with the IVUS?
Sure. I mean, I think you've already done that, and if you feel you have to stent it, go ahead and proceed.
We have taken a long stent, a 3. Do we have a 3.544? What do you think about the length of the lesion if you were to stent right from the ostium?
I think a 44 is probably reasonable.
44 is reasonable. Okay, so we have a 344. We'll use that, and then probably we'll post dilate with a 3.5 balloon.
Okay.
Will that be okay?
Sure.
Now we are using 344 biomime. That's Merrill's sirolimus eluting stent with the biodegradable polymer and 65 micron strut thickness. 344, give that. It said that the drug gets eluted in 30 days and the polymer gets absorbed in another 20 more days. Could you give us a body wire? അങ്കിളെ ശ്വാസം ഒന്ന് വലിച്ചു പിടിച്ചാട്ടെ. ആ വിട്ടോളൂ 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 ശ്വാസം വിട്ടോളൂ. ഓക്കെ വിയത്ര വിട്ടോളൂ ശ്വാസം വിട്ടോളൂ. ഇനി പിടിക്കണ്ട. We thought of getting a buddy wire, but we were able to manage that.
I think you've done a nice job of doing the jiggle maneuver. And it just goes to show you, even after rotation, even after pre-dilatation, this is not easy.
16, 18.
A very nice trick I use sometimes in cases like this is I will put in a wire called a wiggle wire. It has zigzags at the end and allows
Okay.
devices to travel. It's made by Abbott.
Okay. 3.5.
The other thing I do in these cases is I will go up with the balloon twice just to make sure I get expansion. Come back and go higher because this is, he already told us, is a 3.5 vessel by IVUS. And then I think the key thing here is to do a good post-dilatation with a 3.5.
Now we'll go with a 3.5 non-compliant balloon.
Yes, I think that's a great idea.
And then probably we'll give nitroglycerin intracoronary and then stop the procedure.
Absolutely.
I think we have exceeded the time.
You've done very nicely. You have another 5 minutes or so for transmission.
Okay. Okay, we'll go up at 16. Negative. We are going at 16 atmospheres most distally, then at the lesion 18 atmospheres. Okay, 18.
Yeah, you see very nice expansion. Beautiful job with the
Negative.
rotational atherectomy. And you're going to get a very nice, durable result here.
Again 18. Negative. Nitroglycerin.
You see the patient is extremely stable, doing very well hemodynamically. No EKG changes now.
Okay, we end up 18. Negative. Nitroglycerin.
Beautiful
Now,
demonstration.
what about the
Dr.
distal
Davidson.
spasm?
Yes.
What about the distal spasm? Would you want to just balloon dilate it or give nitro alone?
I would not want to dilate it. I would want to give nitro, and you have already spent money on the IVUS. Why don't you use the IVUS?
Yes. We have given 100 nitro. Give us some more nitro. Shall we have a look at the lesion with IVUS?
I think I would do that. I would also, you can even bring the wire back to the soft part and take a picture, but you already have IVUS, so why don't you IVUS it so that you'll know? And we'll leave you in about 3-4 minutes.
Okay, okay, sure. Prior to that, we'll do the IVUS too. Give us some more nitro.
So these lesions sometimes can be pseudo lesions, sometimes can be plaque progression or disease that's been left, and it's clearly distal to where the disease was. So he's going to just take a look at it with IVUS. So often in these calcified
Yeah,
lesions,
the IVUS catheter wouldn't take that. Yeah, it wouldn't take that curve. Now, do we have to persist with the IVUS catheter? It doesn't go through.
well, I would just IVUS what you
Or
can, and then then you decide what you want to do. But you have the
Nitro.
IVUS in the mid lesion, so
no, it's not going through beyond the lesion that we have stented. Now I think we'll pull out the wire halfway through
Okay.
and then give once again nitro.
okay.
100 alle. It looks better, but then
Yeah, it looks like a hinge point almost.
yeah. So what do we do now?
Clearly not normal, and I would say that if the IVUS doesn't go, what does the panel want to do?
I would give a very gentle balloon inflation there. I think it is spasm, and often sometimes you can break the spasm.
Okay.
with the balloon.
2.75 balloon.
All right, so Dr.
Shall we do a gentle balloon dilatation?
Yeah, so that's what's being recommended, and I think you should be ready to stent if you need to, but a gentle balloon
2.75.
inflation is just fine, I guess. It's a little surprising
Yeah,
that the
we would
IVUS
just
wouldn't
go
go.
with a 2.7. We'll go with a 2.75 balloon, dilate it at 4 atmospheres, and then see how it looks like.
He's given quite a bit of vasodilators, so it's hard to make this spasm alone. Dr. Thomas, we'll stay with you for a few more minutes.
Yeah, sure.
It would have been very nice to see the IVUS. I think what's happened here is the vessels
Now
straightened
that
out,
looks
so you've had,
better.
Much
What do you
better.
think right now?
Much better.
Shall we have an LAO-cranial view?
I think what's happened here is the vessel has been stretched a bit,
Yeah.
and that's what's causing it. It's almost a reverse concertina type of effect, and that's what you see in there. It's a
Position.
fold, not necessarily
Position.
plaque shift.
I think we wouldn't touch that. It looks reasonably okay. What do you opine?
You know, I like your index result. I'm okay with that crux. I would leave it alone as well. You know, I would
Yes.
only challenge you to say that that PDA is a dominant PDA. And I know you don't want to touch it,
Yes.
but that might be a consideration to treat that as well while you're here. But that's a different discussion. But I think you've done a beautiful job demonstrating plaque modification in a calcified lesion and all of the pitfalls. Your index lesion is beautiful, perfectly placed. And we're going to leave you, and we want to thank your team at Caritas Hospital
Yeah, thank
for
you so
a
much.
wonderful demonstration. Thank you.
Let me once again introduce our head of the department. He was not here initially. He's Dr. Joni.
Good, thank you.
Thank you so much.